Hi, I'm Ken Chang from UC Irvine and now at Hoag Hospital. And I am joined by my very good friend Barham Abu-Dayyeh from Mayo Clinic, soon to transition to Cedars-Sinai in LA. Welcome, Barham. I can't wait to have you down the street from me in November.
Hi, Ken. Looking forward to becoming neighbors and to collaborating even further in Southern California. So Ken and I are here to discuss and highlight our recent article, which is Outcomes of Transoral Incisionless Fundoplication, the TIF 2.0, a prospective multicenter cohort study in academic and community practices. We would like to acknowledge our co-authors, which include Dr. David Deal, Brett Parker, Jennifer Kolb, Michael Murray, Reem Sharaiha, Ole Brewer Gutierrez, Amit Sohaji, Harshit Kahara, and Peter Janu. But most importantly, we would like to acknowledge the first and corresponding author and really our leader and the force behind the study, which is Dr. Mimi Kanto from Johns Hopkins, for her amazing efforts in keeping us all working together to achieve the study that we're presenting to you today. First, it's always good to go and put things in a little bit of a historic perspective, and origin stories are always good to talk about. I learned how to do TIFF from my colleague here, Dr. Ken Chang, and Mimi did the same. So we could consider him the father of modern TIFF in the United States. With that in mind, Ken, do you mind giving us a historic perspective about the procedure and your thoughts about it?
Sure, Barham. And that's what I love about our GI interventional space. There's such a spirit of collaboration, and we have all learned so much from one another. I learned ESG and suturing from you, and I learned cryotherapy from Mimi. So we're definitely better together as a community. So my first TIF was ancient years ago. It was back in 2008, so 16 years ago. Back then, TIF was really at its infancy, and frankly, not embraced by either our GI nor our surgical societies. The device was early in its design iterations. The technique itself was not fully developed, and more importantly, we lacked robust clinical data. Dial forward 16 years now, and we have now several level 1 prospective clinical trials confirming the safety and the efficacy of the TIF 2.0. However, this registry data looks at the most current device, the most current technique, and this is outside of clinical trials with real-world variability in practice settings. So we have both academic centers as well as community centers, as well as the physician doing the procedure. We have both gastroenterologists and surgeons performing the TIF procedure with varying levels of experience. So this is truly a real-world scenario that we're presenting in this prospective registry data. One of the more important parameters that we captured in this study is we were able to compare patients who were judged to have what we call the optimal TIF procedure versus those patients who maybe did not achieve the optimal TIF procedure. So it does appear, Barham, that our technique does matter. And so, Barham, could you share with us, with your vast experience in the procedure, what defines an optimal TIF procedure, what that looks like, and if optimizing the valve made a clinical difference in our study?
Absolutely. And I think that's one of the interesting, intriguing findings of the study is technique does matter. And we should have known so because we know what's the principles of a successful anti-reflux procedure. And and the interesting part about the TIF technology is now we could recreate the components of a successful anti-reflux procedure. And basically these components we know from surgery is you need to elongate the intra-abdominal esophagus, and you need to recreate the angle of His, and create a high pressure zone, which is about 3 centimeters under the diaphragm. And I think we see that clearly with our results, that the TIF is capable of recreating these components of an anti-reflux procedure. So patient selection is important. So the optimal technique starts by selecting the appropriate patient. Since we are not capable of repairing a hiatal hernia that is sizable, and sizable here is more than 3 centimeters, you need to select patients that truly have small or no hiatal hernia for the standard TIF that's not the concomitant with a hiatal hernia repair. So once you've selected the appropriate patient for the procedure, reproducing the principle of anti-reflux surgery is important. That means you start on the posterior wall of the GE junction, and you wrap wrap posteriorly. Then you go on the anterior wall, and then you wrap anteriorly. Then you go into the midsection of the GE junction complex, and you elongate the intra-abdominal esophagus in order to recreate a high pressure zone. So the components of an optimal procedure that now we have objective pH data to show it matters is creating a 300-degree valve. That means it's partially circumferential, not fully circumferential. And the valve has to have a length of 3 centimeters. And again, this is the high pressure zone under the diaphragm. So these two factors have panned out in this study as important predictors of objective pH control of this procedure. So we're in the era not only with subjective symptom improvement on questionnaires, but also an objective pH normalization with optimal technique. And with that, Ken, I will hand it back to you to describe the rest of the results of the study.
Yeah, and it was, just to highlight the optimal technique. It's not always achievable in every patient because some patients have foreshortened esophagus and you can only get 2.5 centimeters length. But interestingly, in our study, the acid exposure time for those who were able to achieve the optimal TIF valve, the acid exposure time normalized in 94% compared to 57% of those who we could not achieve the optimal valve. So clearly that was a standout result. So I just want to review really quickly the highlights of our findings. We enrolled 85 patients in our TIF registry. These are folks who had confirmed GERD, BMI less than 35, hiatal hernia less than or equal to 2 centimeters from 9 academic as well as medical community medical centers. The procedures, as mentioned, was performed either by GI or a surgeon, and all patients had greater than 6-month follow-up. The primary endpoint was safety and clinical success. The secondary endpoints included symptom improvement, acid exposure time on pH study, esophagitis healing, PPI use, and patient satisfaction. So the highlight results, clinical success was achieved in 94% of the cohort. The GERD HRQL scores improved in 89%. Those who had an elevated RSI score normalized in 85%. Patient satisfaction went from 8% to 79%. And PPI use, while 81% were taking at least daily PPI at the beginning of the study, after the procedure on follow-up, 80% were either on 0 PPI or occasional PPI after the TIF. It was great to see that there were absolutely 0 serious adverse events that were related to the TIF procedure. And as we talked about, the acid exposure time for the entire cohort after TIF normalized in 72%, but 94% with those who achieved the optimal TIF.
These are robust findings, Ken, and again, multiple key lessons that we would like to instill for our readers. And the two I could distill is, one, patient selection is crucial. We need to appropriately classify the anatomy that we're seeing as far as the hiatal hernia and the length of the flap valve. And for that, I refer you to the American Foregut Society classification. It's an important tool to use in order to better stratify patients. And then if you select the right patient, with a small or no hiatal hernia for the TIF procedure, and those with larger hiatal hernia for the combined hiatal hernia repair plus the TIF. You could optimize the outcomes. But what we've shown in this study, that selecting the right patient and having an optimal technique could have great clinical response, but also objective pH normalization in the vast majority of patients, which is a new finding in the era of endoscopic management of reflux, and one it's worth noting, and it's very important. With that, thank you, Ken, for your leadership in this field. Thank you for our co-investigators, and especially Dr. Canto, for putting this study together and this group together. And we're looking forward to further progress in the field of endoscopic management of gastroesophageal reflux diseases. Thank you.
Thank you.